Good morning, good afternoon, good evening. This is Dr. Latasha McElwain, and I am going over the documentation, understanding documentation. This is the North Carolina DHHS requirements. I have not done anything in this presentation to give any different from what has been stated by the North Carolina DHHS requirements. Therefore, I'm going to go through it and give some good pointers and things for anyone that's coming into the human services field to start understanding how documentation is viewed in North Carolina agencies. All right. So the value of record keeping, pretty much an agency that has staff persons who embrace and promote good record keeping practices will go far in documenting clinical assessments, treatment, and outcomes, ensuring accountability and reducing legal and other risks. So for the most part, when we're talking about agencies that come under North Carolina DHHS, we want to make sure that those agencies and the staff individuals that are working in the agencies understand that record keeping is extremely important. Record keeping is what's going to keep the agency relevant, and record keeping is what's going to keep the agency open for services. Making sure that everything is documented is a big part of wanting to ensure accountability, wanting to have great outcomes, evidence-based outcomes, and the services that are being rendered are making sure that the individuals are working through their treatment goals, their treatment plans, and of course, those assessments, making sure that they're documented clinically and appropriately so that individuals will realize that there are concerns from the assessment. Those concerns will go into the treatment plan. Those treatment plans will be completed as far as having the documentation of notes that go along with the outcomes that will come from making sure that you're implementing the treatment plan and making sure that you're conveying and capturing all the different things that go along with the evidence base of the outcomes that we come to per client. So again, all of our notes, assessments, treatment plans, even the outcomes we come to with each client is person-centered. So it is critical that the agency leaders and supervisors demonstrate a commitment to the vigilance of the note taking and the record keeping practices. So basically, we want to make sure that this commitment goes across from the head all the way down to the working staff that are face to face with our clients on a daily basis or on a regular basis. So all of our staff members, we want to make sure that they embrace and promote, again, good record keeping practices. I know many agencies are going from paper form to digital form right now, and that is a major thing as well, making sure that we are keeping the records and keeping the documentation on point, not only on point, but making sure that we are reducing the amount of legal and the other risks that can come along with making sure that our documentation is in place and is at A1 standing. Documentation of notes for state funds. So basically, there's a process that have to be gone through when it comes down to documenting the notes. Documenting the notes, so per service definition, all of our notes must meet the best practices guideline for services, as well as the fact that we are billing state funds. So we must comply with DMH, DD, and SUS, North Carolina Tracts Benefits Plan reimbursement guidelines. So we have to stay within that. And then we also have to realize that the goals that we have relate to the goals in the individual PCP. So all of the whole process of what we're doing is going to basically roll into the PCP, but all of the information that we are capturing in the notes in the clinical assessment, in the PCP. All the information must be related to the goals that we have in that PCP, and of course, all of the interventions and all of the different techniques that we're using to work with our consumers, members, clients, patients. So yes, and you'll hear me use the different ones that I just gave just now, as far as the consumer, the member, the patient, the client, because you will hear all of those when we're talking about all the services that we provide. But all of them is talking about the recipient, pretty much, the recipient of the services. So when we're talking about all services, so related documentation must meet the requirements outlined in the records management and documentation manual and the person-centered planning instructional manual. So all of these manuals are manuals that individuals are trained on when it comes down to providing state-funded services and doing the notes and all of the documentation. All right, so meeting the guidelines and the guidelines for documentation. So meeting the guidelines for documentation, we have to make sure that our notes are accurate. We have to describe the fact as observed and reported. If you look at notes, sometimes you'll see that most of the clinicians, the QPs, the APs, the PPs, individuals that are providing a service, your doctors, your PAs, your nurse practitioners, they are describing facts as they are observed or as it's been reported from the client. So client reported, staff observed, or, just kind of given more in-depth description of the facts that are being, again, observed and reported. Okay. Describe what you are witnessing and observing and or what is being reported. So you are making sure that you are describing, or you are definitely letting them know what you're witnessing, basically the behavior that you are seeing, and what is being observed, basically what are you seeing again, and then what is being reported. The client reported that so we want to be very specific with that, as in what they are reporting. I usually tell individuals you can also utilize the fact of quotation, so you can quote what the individual has said, what the recipient has said is happening or what is going on. So as they report, you can put quotes around it if you would like, or you can just put the individual reported. You can definitely put the client reported, client report, So those are just basic type ways, but you definitely you want to describe what you are witnessing, observing again, and what is being reported. We talk about the timeliness of the report when we're meeting the guidelines for documentation. Timely, we have to record. The recording is significantly important. So at the time of the event, to avoid inaccurate and incomplete information. So we have to be able to give the information at the time of the event as to what's happening and what's going on. So when we're talking about timing, we still have to tell individuals when things occurred, how long it went on for. We want to be able to have a timing component in there. So when an event occurs, recording is important and must be done at the time of the event. So I always tell folks, if something happened and yes, it transpired and happened, and you have a lot of events happening, then documentation is important to get it done truly as soon as possible. Right after the event, we need to write it up so we can be very accurate and very on point as to what happened in the event. The other thing is all information should be accurate, and information should be complete. We want to make sure that we have accurate information and we have the information complete. When we're talking about objective, so recording facts and avoid drawing conclusion. So we can't say what we thought someone was thinking. We don't want to start drawing conclusions. We want it to be very factual. We want to record what happened. So professional opinions must be phrased to clearly indicate that it is the view of the recorder. So when you're writing things up, I always tell people there's power in the pen. You have to make sure that you are writing things up as it is factually happening and not drawing conclusions. Professional opinions, again, must be phrased to clearly indicate that it is the view of the recorder. So whomever's recording, whoever's, recording this information, you must make it very clear that you're indicating that it's the view of the recorder. It is your view. A lot of times I like to tell people sometimes professional opinion, if it's not asking you for your professional opinion, then, adding your professional opinion where it is appropriate for you to add your professional opinion. Okay. Typically, I say that to some of the licensed professionals because there is normally a portion where we have to give our clinical judgment, our clinical summary of what's happening and what's going on. We have to give our intake on what we are seeing. Okay. So, and that a lot of times is in our assessment when we're doing a clinical assessment. So please ensure that you are recording the fact of what happened. So you want to make sure that you, again, we're talking about facts. You are here fact a lot because the fact of what happened will be drilled upon if there is a audit for any reason or any type of reviews for any reason or when questions start to come up. Factual basis is what we want to stick to. We want to stick to the factual basis. Do not draw any conclusion of what you think, as well as when giving a professional opinion, you must it must be phrased to clearly indicate what the viewer recorded. Example, this is a great example right here. It appears that he was upset. If you're going to tell them what the professional opinion is, it appears always works. This is the example that the state gave. This is the example that we want to make sure that we always lean towards. It appears, it appears, it appears. That is clearly letting us know that that is your professional opinion. Next one, when we're talking about meeting the guidelines for documentation, we want to be specific, we want to be concise, and we want to be descriptive. So recording in detail rather than in general terms. So being brief and meaningful without sacrificing essential facts. So we don't want to not get the essential facts in there. And thoroughly describing observation and other pertinent information. So we want to make sure we are specific, we're concise, we're descriptive. We want to put all important information in there. We want to make sure general terms are pretty much left out. We don't want to go with general terms. We want to tell what happened. We want to be brief about what happened. We want to make sure we're concise about what happened, and we want to be very descriptive. We want to make sure that we are given the essential facts to the scenario and what's going on. Pertinent information, we want to make sure it's in there as well. When it comes down to the notes, we want to be sure that your notes are specific, they are concise as well as descriptive. We want to be detailed. We want to be very brief and meaningful, that we are putting what happened there. And we want to include what was observed and share the pertinent information. So we also want to tell what was observed. We would definitely want to make sure we put that in there because that gives a lot of information that could be definitely the pertinent information that's dealing with any situation, any and all situation. So documentation is extremely important to make sure that we, again, avoid a lot of the legal ramifications of things that can come up and things can be questioned, of that nature. For the most part, we want to make sure that we're on point and we are being specific, concise, and descriptive. Next, when we talk about the consistency, we want to explain all contradictions and given the reason for the contradiction. So we want to make sure that we are consistent with our documentation and that we are moving forward. If, like I said, there's any explain any contradictions and give the reason for the contradiction. So we want to make sure that we are very precise in handling that as well. Comprehensive and logical and reflective of the thought process. So basically, when we're recording significant information that is relevant to an individual's condition and course of treatment and rehabilitation, we want to make sure we are pretty comprehensive. We want to make sure we are very logical in what we're doing and what we're stating, and we want to be very reflective in our thought process in doing this. So document pertinent, excuse me, basically when we're doing the findings for our documentation, we want to make sure that we have the pertinent findings. We also want to make sure that we are looking at the services that are rendered and will be rendered. We want to make sure that we're on point with that. We're talking as far as changes in the individual's condition. We want to be very comprehensive in giving and talking about what's going on with the changes in the individual's condition. We also want to be able to respond to treatment. So the response to treatment, we want to talk about what's happening with the individual responding to the treatment that they're getting and the rehabilitation that they're getting. We want to make sure that we have the response to treatment on point as we're giving this information. Also, we want to make sure that we are giving the appropriate information. So if no one's asking for the response to treatment, then we're not addressing that. But in most cases, if the response to treatment and rehabilitation is coming up, which will come up in many of our notes, it is appropriate. We have to do it as it is requested, and we have to make sure we give the information. We have to include justifications for initial services for our clients, as well as continued treatment and rehabilitation that is needed for the client. And then we also have to look into documenting the reasons for any atypical treatment and rehabilitation that is utilized. So I'm going to jump a little bit in here and just talk specifically about the comprehensive logic and reflective of the thought process. So when we're doing our notes, we want to make sure that we are going through our goals appropriately, make sure that we are coming up with the intervention and we are describing those interventions, what we're doing, the services we're rendering, how we're providing and doing the things that we're doing. When we're talking about the effectiveness of what's going on with the client, we are talking about what is happening with the response to treatment from that particular individual, that client, that member, consumer. We want to make sure that that patient is getting what they need, and whether there is a change in their condition, as in they are, getting to a point where they're understanding what's going on. They're definitely receptive to what we're talking about. They are showing different type of behaviors and different things of that nature that is showing that changes are happening in their condition. Okay. All right. We want to make sure that our documentation is clear. We're recording meaningful information, particularly for other staff involved in the care or treatment of the individual. We want to make sure that our information is coming across clearly. Okay. Write in non-technical terms to the extent possible. So we don't want to have so many technical terms running through. We want to have non-technical terms, and we want to make sure that we are being very, again, meaningful with our information, and that we're putting out our information that is working for the individual, so that when other staff members come in and they're able to pick up this chart or pick up this information, they're able to move right along with the process of what's going on with this particular individual and the treatment outcomes that we are, moving towards and things of that nature. So we want to make sure the care is actually consistent and that the care is continuum, and making sure that it is clear for the next person to come in and pick right up and move along with our particular consumers, clients, patients. Okay. So when we're talking about pie notes, we want to make sure we have our service date. So our service date is important. This is information that I am given that is specifically from a note, a pie note that would be completed for any client, consumer, individual, recipient, patient, member, however you state it. We are going to make sure that we have the date of service that is required. We also have to make sure we have the identification of recipient, which is if it's different from the client. So technically, if it's the client being service, and then if we are servicing, let's say the identification of the recipient is the family, so the client and the family, so the client and the parent is there. Or if we are, doing pie notes in other realms, if we're writing up a note, we would actually do, if we're meeting with the client's, say, teacher. So that would be their, support persons or individuals of that nature. So basically, if we were writing a pie note for the purpose of being in the services we're doing, then we are actually putting, who the recipient is, who we're doing this service with. And everyone knows how billing set up in, well, everybody may not know how billing set up, but billing is set up based on the codes that we're using for the particular services that we're actually providing. So if we are doing um, I don't want to go too much in the codes, but if we're doing a code for an individual session, then we have the 908 code if it's a individual session, and we're doing counseling per se, or whatever the code may be if we're doing a family session. If it's a service within the home, we still a group home. We need to make sure that we are, the service is happening with the individual child for the most part, and we're doing the service based on that recipient. If it's a service where we're doing outpatient services like a peer support, or we're doing a service such as if we're in a facility and we're doing inpatient note, then our client is our targeted, identified recipient. Unless we have, again, a family session happening or a meeting that's happening in a treatment team setting, which notes may look a little different. But we want to document what we're doing. And documentation is major when it comes, again, across the fact that if it happened, it should be documented. The purpose of the contact, that's going to be the purpose of the contact, Medicaid ID number. So basically, the Medicaid ID number of the individual. Okay. The description of the intervention, basically telling what the intervention is all about. That's going to be in there. And then the effectiveness of the intervention. I'm sorry, let me step back to 3. The purpose of the contact, that would be pretty much with the goal. The purpose of the contact is usually the goal. The description of the intervention is usually what is being done, what is being given, or what is being the techniques or the use of what you're doing with the particular client. And then the effectiveness of the intervention. How did it work out? What went on, and what did we, what came out of all this? We're also going to have the record numbers involved as well on our notes. We're going to have our Medicaid numbers on our notes. We're going to have our who our identified patient is on our notes. We're going to have the duration of services. So all excuse me, all periodic as required by the specific service, and otherwise required as otherwise required. So basically, we would be making sure that all of these services are in place, and we understand what the duration of our service is. So if we're doing a daily service, we want to make sure we have timing in there. We have certain things going on in there, as in we're doing an individual service, we're doing a group home note, or whatever the case may be. We're doing an outpatient service. We're doing peer support. We're doing outpatient session. We're doing whatever that service is in the duration of that service. If it's a 1 hour, if it's a 30-minute, if it's a full shift. So, that goes into learning and knowing about some of the per diems and different things of that nature, as in going through, the different services that you're providing. So the duration of the services, was it 1 hour? Was it a 1 hour service? Was it 45 minutes? Was it a whole shift where we were actually working with individuals? So these notes, we do have to be considerate of our notes. Some of our notes can be, depending on what service we're providing, could be a 4 hour note that we are in there providing the goal, intervention, and the effectiveness for a 4 hour note, the different things we did in a 4 hour stint with a particular client, particular family, whatever the case may be. The professional signature, you got to have the degree, you got to have the name, you got to have the degree, you got to have the credentials, you got to have the license. Same thing with the paraprofessional, you got to have the signature, and you got to have the positions as well. Um, so moving right along into some of the good things that you need to know about. Basically, when we're doing documentation and services, you're going to have the assessment. So the assessment is a comprehensive examination or evaluation of person's needs for the psychiatric, developmental, disability, or substance abuse treatment services and or support according to applicable requirements. So basically, when we're looking at the assessment is a document that typically is done, usually your CCA, your clinical assessment is going to be done by a licensed clinician. The information that's coming from the assessment is going to come from what has been observed, what has been talked about, and what has been proven as different things that can be done, or so the assessment is kind of branched out into different areas. You'll see all kind of information on there. You'll see the reason why the assessment's being done. You'll get all the background information. You'll see information about what's going on with a person as far as their substance use, no substance use, whether they're dealing with the developmental disability, what's going on there. You'll get information from mom, dad. You'll get information from the person themselves. You will go through if you have been in the field a long time, you will go through a magnitude of assessments. So there are psychiatric assessments, they are the clinical assessments, there are different levels of assessment. This could be suicide assessments. And so there's so many different types of assessments that can occur while a person is in services to make sure that we are addressing the needs of an individual. So as you're going through, if you're new into human services, you probably see your clinical assessment, you see your initial assessment, you'll see maybe even a psychiatric assessment that has been done, and some ongoing services around there. So assessments come in many different forms. After a while, you may even see the medical assessments that are done by the medical doctor. So many different assessments come into play, but all of these assessments we put together and make sure that we are providing a person with all the needs that they need, because we are starting to look at the whole person approach. And so because we're looking at the holistic approach, taking the whole person, we are looking at on our side of what we're doing for this specific training and this specific supervision presentation. Psychiatric, developmental disabilities, and substance use is typically what we're more geared toward and what we see. But like I said, if you're working in different levels of services, you'll see that you will have medical assessments, you will have psychiatric assessments, you will have developmental different types of assessments, like a physical um, physical and occupational assessment being done to see what the person's needs are there as you're working with the developmental disabled populations. When you're dealing with substance abuse, you'll see all types of assessments also, but you will also see some assessment screening tools that are come in place, like your SASE, and you'll see the ASIMV. You'll see different, I think there's one that's also called the SALSI, but you'll see different levels of assessments in that area. So if you're going to be in this field for a quite long period of time, for the most part, I've been in 20 years, so I've seen all different types of assessments. And so I say that to say, you'll start to see those comprehensive evaluations done, or those comprehensive examinations completed. Reading through them to help understand your particular clients and what's going on with them is very helpful. Knowing, because a lot of times from the assessment, that's where you're going to come up with your goals. When you come up with your goals are going to lead into the interventions you're going to be providing. This all goes into the treatment planning area. These interventions you're actually providing you will go into the effectiveness, as in how these goals, interventions, and then the effectiveness will tell you how the treatment outcome is going, what's happening, what's going on, and you'll be able to move further into how you're working with an individual. So I like to tell people, when you think about human services, you're coming into a building blocks of different activities that are happening to make sure that a person have a final outcome as to what the service is, the treatment that we're providing, and everything else. So the assessment is first. Um, Along with assessment, I'll just jump into, um, before I get to best practices, the assessment will start out. In that process of the assessment, you'll have the intake that's happening. You'll also have probably some orientation that's going on. You'll have all of this happening to make sure a client, a recipient, the individual is aware of what services, or the parents are aware of what services that are going to be involved and how things are kind of going. So assessments right up there again with orientation, assessments right up there with talking about the intake. Orientation is intake. Orientation is basically making sure that a person knows what's happening, what's going on. Intake is really making sure that an individual is aware of the treatment services, and then the individual that's doing the intake typically is making sure that the person that is coming into services meet the criteria for the services. And then the assessment also helps with that as well, making sure that an individual meet the criteria and have the needs that they need, that needs to be formulated into a treatment plan for goals, in order to have then the interventions that need to go in place, and then the effectiveness, as in what's going on and what are the outcomes. So this is what we're getting to when we start talking about evidence base. Going into best practices, interventions, treatments, services, and action that have been shown to generate the best outcome and results. That is what we're working from. The term evidence based comes into place, or research based. All that goes into what I just stated, as in the process of what we're doing when we're working with our clients. Um, so I'm going to jump on into talking about coordination of service. Before I go through this piece right here, I'm going to also mention that when we're doing the assessment, the intake, the orientation, once we get all that information all together and we have a good pace that, okay, this person has needs, we're going to go ahead and start treatment planning. When we start the treatment planning process, the treatment planning process can be when we're really coming up with those goals, those interventions, and then what the outcomes that we're looking for, what the evidence is going to show, what the research is going to show, basically having an outcome of the results from what's going on with our clients, with the individual designated client. So in this treatment part is where we come up with our counseling sessions, our services that we're providing in homes, services we're providing in inpatient settings, services we're providing in outpatient settings, services we're providing in general. That's where we're getting our best practices and our evidence from what's happening in this treatment piece, the treatment component. So care coordination happens as well. Care coordination is usually basically in care coordination in the 1915 BC waiver is specifically focused on the unique individuals, the unique needs of the individual with mental health, substance abuse, and intellectual or developmental disabilities at hand. So basically, the coordination basically is what is done typically. Care coordination should be usually is happening in the element in the MCO. They provide this coordination to make sure all these services are coming together and the different things are happening, and making sure that we are supporting our individuals in the services that they're providing. So education about all available mental health, intellectual disabilities, developmental disabilities, and substance abuse services and support, as well as the education about all types of Medicaid and state funded services. So this is where the coordination, they have to be, I like to say, vested and very involved in creating and making sure that that coordination is happening across the board for all the consumers that they are helping to provide services for. Linkage is needed for different psychological type services, as well as behavior services, educational services, and physical evaluations. So all of these services, understanding what linkage looks like, that's connecting individuals to these services, making sure the coordination is happening, and making sure the services are carried out. The particular, if there's an occupational evaluation that needs to be done, it is done and it is carried out. If there's a physical evaluation need to be done, it is done and it is carried out. Development of the individual support plan. So the ISP or the PCP, the person-centered plan, in conjunction with the recipient family and other service and support providers. So making sure that all this is kind of brought together and that these services are carried out. Also, that everyone is aware and involved in these services and making sure that everything is happening. The monitoring of the individual support plan, as well as the PCP, the person centered plan, and the health and safety of the individual, that is also happening in coordination. So, the coordination of the Medicaid eligibility and benefits. So, all of these services that are involved in the care coordination is a part of what's happening. That is a great part of what really happens as far as the services we're providing. We're making sure that all of this is happening and everything is going across the lines, and making sure that we are putting all of these services in place and these services are happening. Again, we are executing. So care coordination, I like to say sometimes, is the executor. They're the ones that's making sure that if there's a service that's needed, we're going to link you to that service, and we're going to make sure that everything is carried out as far as making sure that those services and evaluations are completed. And then we are moving along to make sure everything's incorporated into the individual support plan or the person center plan, to make sure that we move along through services and again have those outcomes that we need to have, that shows the evidence base or the research base that everything is occurring. So this is best practices. Also, we're just moving through what is information that you guys need to really be aware of and know of. When we're talking about the comprehensive clinical assessment, we're going to go back to that right quick and talking about basically this is an intensive clinical and functional face-to-face evaluation that is going to occur with the individual presenting the mental health and the individual presenting mental health, developmental disability, or the substance abuse condition. So basically, this service is going to happen with them and with their parents, and probably even with some other individuals as well. The result of the clinical assessment is to ensure of a written report. So a report is actually created. That's the clinical assessment, the clinical comprehensive assessment, a comprehensive clinical assessment, to provide the clinical basis for development of a person-centered plan. So that's where we're getting the PCP from, is from the comprehensive clinical assessment. Those recommendations will also be in there for the services, the support, and the treatment that is needed. Additionally, when we're looking at the comprehensive clinical assessment, we will have all of the providers involved in that assessment to make sure that we're making a great recommendation or great recommendations for the services that are needed, the supports that are needed within, as well as the treatment that will be given to this individual. Moving to confidentiality. So the confidentiality of our patients, we have to keep our information private. We have to keep our information confidential for our individuals, allowing the records or information to be seen or used only by those with legal rights or permission. So those individuals that are providing services, we have to make sure that we are making this information available in private. So this is private information of individuals' condition, their what's happening and what's going on with them. These are medical health records for the most part, mental health records. We want to make sure that we are on point and we understand what confidentiality is all about. We'll move more into HIPAA and talking about that a little bit later, but I mean, a little bit later in this presentation. But we want to make sure that we're well aware of confidentiality. When we're talking about consents, we want to make sure that we have consent forms. So consent forms are the given approval and agreements to something. So basically that we are getting consent from parents. We're getting consents from individuals that are dealing with the individual's care, we want to make sure we have consents on file that we can speak to individuals. We can't just willy nilly give off information about our consumers to anyone. So, given approval and agreed that we can actually give out information to different entities. For example, in education, parents must give consent before a child can be evaluated or placed in special programs. Also, consent is usually documented in writing and may be given for regular treatment. So those consent forms have to be completed. So consents go into consent forms. Verbal complaints, I mean, excuse me, verbal consents. We try to stay away from verbal consents, but we try to document whenever we get a verbal consent and paperwork is not done. But I always like to tell people if paperwork is not done, even though we got a verbal consent, let's follow up with the paperwork because it is needed. That keeps us out of legalities and the legal ramifications of things when it comes down to consents. If you didn't document that a verbal consent did did not occur, if you didn't document it that it occurred, then technically it did not happen. So you want to make sure that you always document the verbal consent and then you follow up with the verbal consent form to make sure, I'm not, excuse me, the consent form that it is being consented on also in writing. Okay. I can't continue to stress that the importance of that. I continue to stress it and stress it and stress it, but I can't do it, enough pretty much. So when it comes down to emergency medical care and things of that nature. Also, participation as a subject in a research project or anything like that. All of this must be consented upon. The individual giving consent to a particular situation must have legal authority to do so. Okay. So we just can't give information to grandma because grandma called. We have to make sure that person have legal authority to get that information. We have to make sure that mom and dad said yes. Include Miss Jenny Jones because Miss Jenny Jones is grandmother and she can have all the information I have. Or she can have specific information regarding visitation. But that's all the information I want her to have because she will make visits to my child every other weekend if I am not able to do so. So we want to make sure we're very specific when we're talking about those consents. And a lot of consent forms now gives us specific things that we can share and specific things that we can't share. So if those things are not checked, we're not at liberty to share. So if a person say, well, I want them to know what's happening based on the fact that I came to the hospital or I came to, services. And so you can answer, yes, he is attending his services. What days did he come? They really have to tell us to be able to give them what days that they actually showed up at the hospital, what days they actually, came in for the outpatient services. We really want to be more specific about that to make sure that we're even giving away the correct information. And again, to persons of legal authority that is supposed to be getting this information. The person who's giving us the consent have to have legal authority, and they're saying that we can give that information to grandma, grandpa, this doctor, that doctor, or whomever it is. It's like I said, I can't continue to stress that importance enough about the consents and confidentiality. All right, consents for participation. We definitely have to have a signed agreement to take part in treatment required for children and adolescents receiving substance abuse treatment. There is more specifics to that. As we get children and adolescents that have substance abuse treatment concerns, we have to be more mindful about that because of the fact that at a certain age, and I believe that age is 14, I can double back and check, but at that age of 14, they have more say as to what we can share with parents, what we can share with other people about their condition and their concern. So in the substance abuse world, there's a whole gamut of information that goes along with that. And then as we go into consultation, we definitely want to make sure that we are definitely, go back, I'm sorry. When we're talking about consultation, we definitely want to make sure that we are meeting the requirements, basically, The consultation meeting is a meeting where all of the experts and the professionals are coming in, such as the medical doctor, in order to seek advice. So, consultation is sometimes like our staffings, consultation is sometimes like our clinical supervision. But basically, we have a meeting of the experts and the professionals. We're making sure that we are getting some advice, seeking more advice as to what we can do, what the outcomes, what we want the outcomes to look like. We want to make sure that we are adequately supporting our members, our clients, our patients, and providing them the services needed and the services that needs to be rendered, and the specific ways that we'll go into providing services. And like I said, getting that seeking that medical advice is going to be important. Having those consultations with medical doctors, that being the psychiatry team, that being the NPs, nurse practitioners, are the PAs, the physician assistants. We want to make sure that we are doing our consultations. The clinical team as well, when it comes down to the licensed professionals, the therapists that are on the cases as well. We want to make sure we're getting that. The QPs give us great consultation as well, because they are definitely with the patients more than the actual professionals or the experts may be. The professionals and the experts are in there for the support that they give, and the therapy and the med management type situations that they give. And then a lot of times the paraprofessionals, the QPs and the APs and the peer supports, they're with the individuals for a longer period of time. When you start getting to the licensed professional, those individuals are really individuals that are checking in and making sure that they're providing the interventions and the treatment that they're supposed to be providing, but together, a collective team. That's what we're talking about, the consultation. And like I said, talking about staffing and talking about more specific supervision. All right, so day and night services, we want to be mindful that services provided on a regular basis in a structured environment. This can be environments like group homes, this can be environments like intensive outpatient programs, this could be day treatment programs, it could be partial hospitalizations, this could be developmental day programs, this can be PSR programs, with your psychosocial rehabilitation programs, your supported employments, your community rehabilitation programs. It could be, a different, I kind of mentioned all of them here, but they're your 24-hour residentials. So basically, let me go through this right quick. Let me read this whole thing before I continue to share. Basically, they are offered to the same individual for a period of 3 or more hours within a 24-hour period. The term generally refers to services that are a part of daily or regular group programming, but are not 24-hour residential services. So these are your services that you are providing, day night services, basically not in the residential setting. So the residential setting is more 24-hour. That'll be your residential setting, as well as your inpatient and things of that nature. This is a little bit different. So this right here gives your partial hospitalization, your substance abuse, intensive outpatient services, day treatment programs, developmental day, all the ones that I just mentioned just now. So this is your day night services, providing services on a regular basis, okay, for a period of 3 hours or more. So this is more than 3 hours in a 24-hour period, okay? So that's your day and night services. We're moving right along, and we're speaking about the discharge plans. Discharge plans is a document generated at the time services is terminated, that contains a recommendation for further services designed to enable the person to live normally as possible. So discharge planning, I'll be honest with you, typically you'll hear this in the world of human services and counseling and social work. Discharge planning begins at intake. So basically having documentation of what the outcome for this individual is going to look like after we take them through services. It's almost like forecasting what we're going to do from intake all the way through treatment to the end of services, what discharge is going to look like. We are making sure that the individual is going to be able to move through with services. So documenting this information is important as well. I always tell individuals, again, we start discharge planning at the first day that we see a person. So the first day of intake, we're pretty much forecasting what we would like to see and what could be the outcome for this individual as they're telling us what they're wanting to do. Basically, transition back into their home, transition back to live with their family, transition back to being in, society, doing things as normally as possible. Whatever the case may be. Individuals coming in for therapy, we do the same thing. Individuals come in for residential, we do the same thing. We want to see how we're going to be able to transition them back into society and doing the normal things that they would be doing as normal as possible. Okay. Duration. We're talking about duration. We're talking about the total amount of time spent performing the intervention. So sometimes we go into the duration of services. As a therapist, we look at 1 hour, 45 minutes, an hour and a half, whatever the case may be. When you're looking at group home services, you're definitely looking at the shift that you're working. So if you're working 7 to 3, that's your shift. From 3 to 11, that's your shift. From 11 to 7, that's the shift. So the duration of time that's being spent performing the interventions. When applicable, you also look at this amount of time is documented in your service notes and is billed within payer reimbursement guidelines for the service. So basically, as the reimbursement guidelines state out for the service, you will be completing these notes. These are the service notes, and you will be billing for the service. So I always tell people when you come into human services, all services you provide is a billable service. So that's why we want to make sure that we keep strict documentation on what's going on. The duration is required to be recorded for all periodic services unless the periodic service is billed on a per event basis. So for all the services as required by the Medicaid state plan, for all services as required by Medicaid clinical coverage policies, and then whatever the duration is required by the service definition. So duration is a big thing that must always be documented. We have to put the duration of the time that we're working with individuals, the duration of an event if something happens. We have to put that in. A lot of times I do hear the QP state that the event happened for about 15, 20 minutes. Okay, thank you. We need to know how long the duration of whatever happened, if it was a crisis or whatever the scenario was. We want to know the duration of what happened. So duration is very important. Moving right along, the evaluation, more in depth than an assessment, examination of the specific needs and problems by professional using specific evaluation tools. So typically, I like to jump in this part of talking about evaluation, kind of like when we're doing substance abuse component of things. When we're looking at the substance abuse component, we have evaluations that we do provide, which are kind of like our assessment tools for the most part. And basically, it's more in depth again than an assessment, and the evaluation basically goes in depth. A lot of times on the mental health side, you will hear about a psychological evaluation, which goes more in depth than a clinical evaluation, or goes more in depth than the CCA, the clinical comprehensive assessment, the comprehensive clinical assessment. Moving right along from there, we're talking about evidence-based practice. We mentioned that earlier, talking about the fact that we basically referring to the research-based treatment approaches, the protocol that has been found to have clinical efficacy as well as effectiveness. We definitely want to make sure that we are going through this process of finding out what the evidence base is for the individual with certain emotional and behavior challenges. So we want to make sure that we are going by the evidence-based practices. And a lot of times when we talk about evidence-based practices, a lot of times you'll hear people talk about cognitive behavior therapy. That was a big evidence-based practice for the state of North Carolina for years. That's the one that I came in on. There are other evidence-based practices that the state of North Carolina utilizes as well. But one of the ones, like I said, that I came on was CBT, the cognitive behavior therapy. First responders, when we talk about first responders, all these things that I'm mentioning are parts of what we're doing, not only what we're doing, individuals that are involved, as well as documentation that is needed to provide in all of the aspects of what we're doing. First responders is the provider designated to the PCP to provide crisis response on a 24/7, 365 basis. So basically, typically the first responder is the provider who has the most consistent contact and familiarity with the clinical dynamics of the individual being serviced. So a lot of times our first responders, the person who has the most contact with the individuals, are the individuals that are in the home, if it's a home environment, individuals that are in the inpatient facility, if it's an inpatient environment, individuals that are providing the outpatient services, that are the clinical, that are the providers, and then also individuals that are definitely in the residential. So a lot of times, these individuals are the crisis response person. It's usually a QP. Sometimes, depending on what's going on, it could be an LP, depending on what's happening, what's going on, and what services being provided. It could be, a person on the team that has the most contact and the most clinical information with what's happening and what's going on with this particular individual in the case that they're actually servicing and providing services. So that's real important to know. There are most dynamics to go into when we're talking about the PCP and the first responder and the crisis plan that you'll get more information about as the training continues, or as your service in human services continue, your services in healthcare continues. For the most part, you'll get more about first responders and the PCP and how things follow up through crisis planning. Follow up is the process of checking in on the progress of the person who has completed treatment or other services, has been discharged, and has been referred for other services and support. So follow up is just making sure that individuals are getting the services they need. Follow up can also be following up as they're in treatment. Usually our care coordinators are following up, and our individuals that are working with our patients, on a regular basis, are doing follow-ups for the most part. Follow up is kind of helping with the continuum of care also, and making sure that we are able to make sure that that person's care is continuing. And again, a little bit of coordination still happening there as well as needed. The guardian, of course, is the individual who is legally responsible for the care of the child or adult who is incapable, or definitely to take care of themselves, or definitely sometimes even considered they have the lack of capacity to do so. So if there are basically court-appointed individuals, they're often responsible for taking care of the child or the incapacitated person. The person who's incapable of taking care of themselves, they will take care of all of the affair. So a legal guardian may also provide permission for the individual to receive treatment. Also, a person appointed as the guardian of the person, guardian enlightenment and things like that. Those individuals come into play. Basically, a general guardian are placed in place by the courts, and it's under Chapter 7A or 35A, or former chapters 33 and or 35 of the general statute, that individuals have these guardians in place. So guardians give us permission to do particular things with the individual. A lot of times I tell individuals to really stay involved as professionals, stay involved with the guardians, stay involved with the parents, and make sure that you are getting consent. You're making sure that they know about things that are happening, and they know of different things that, are transpiring with our individuals that are in care. Okay. So next, we're going to talk about HIPAA. I mentioned it a little bit earlier, the Health Insurance Portable and Accountability Act. When we're talking about HIPAA, it's a federal act that protects people who change jobs, are self-employed, or who have pre-existing conditions. The act aims to make sure that prospective or current recipients of services are not discriminated against based on their health status. So HIPAA also protects the privacy and security of an individual their protected health information. So protected health information kind of goes back to our consent forms and goes back to our confidentiality. We cannot release that information to anyone. There is a big fine if there's a HIPAA breach of HIPAA. So all that stuff have to be considered when you're coming into the field of healthcare, for sure. Okay. More information about that. You'll continue to hear more about it and specific trainings and different things of that nature, supervisions as well, documentation. We will be giving more, or you will be getting more as you're growing and learning in this field of human services, healthcare, social work, counseling services, therapeutic services. Okay. Incident and death reporting. So incident reports are important. We have to talk about the incident reports. We have to talk about the IRIS system, which is the incident response improvement system. We have to talk about it because a report of any incident usually occurring, medication error, even if there's a death of a person that occurs while individual is under care of a service provider, that have to be taken care of in order to maintain authorization to provide publicly funded mental health individual, excuse me, IDD, which is your in your substance use services. So basically your services, basic, excuse me, let me say that again. When you're providing services, you must fall, when you're providing services under the public funding, you must follow the mental health, the IDD, and the substance use services and good licensure status. So you have to stay within the, you must keep everything a point and you up on point, and you must make sure that everything is, you have to maintain that authorization to make sure that the provider must follow the requirements for incident responses. So you have to report. It is set forth, of course, in 10A NCAC 27G 0.0600 in accordance with section 4.5 of the NC Session Law 2002 164, Senate Bill 163. So that's pretty much what we have to follow to make sure that we are following the full details of the requirements, and make sure that we're consulting with the administrative code and the DHHS incident and death reporting manual. So we have to make sure that we are on point and that we have all of this in place. And this is a considerable area that we have to follow along with. This is a requirement. So we have to know about incident reporting and we have to know about death reporting. So we have to make sure we follow the guidelines. The incident reporting system is called IRIS, the Incident Response Improvement System. This is a web-based incident reporting system for reporting and documenting responses of level 2 and level 3 incidents involving consumers receiving mental health, developmental disabilities, and or substance use services. So I'm going to go back right quick. When you see MH, that's always mental health. When you see IDD, that's always intellectual developmental disabilities. And when you see SU, that is also referring to substance use services. Okay. We use a lot of acronyms in this field, so we want to make sure that individuals are aware of it. But IRIS is the reporting system that these level 2 and level 3 incidents have to be reported to. And we can talk a little bit more about level 2 and level 3 incidents a little bit moving into more services and more trainings. We'll talk about those. But for right now, just understanding that these and what constitutes a level 2 or level 3 incident. We'll talk about that more as we're going into services. But you want to be aware that there is a system out there to report in the state of North Carolina. It is called IRIS. Okay. Individual educational program, we want to talk about IEPs. So IEPs are for our adolescents and our children that have special needs. So basically, it's a written plan for a child with special education services, the special needs services in place. The plan is based on a result of evaluations, and that is a full evaluation, usually psychological evaluation, a whole set of evaluations that the school will come to terms with, and the school will make sure this child has this IEP in place. Once all these evaluations are put together, the IEP is developed by the team, and they also include the child's parents, the teachers, other school representatives, specialists, and the child when appropriate. So mostly, I believe the child usually come into play around 12 or 14 is when a lot of kids start to be present in the meetings. And I might be wrong with the age here, but I'm still giving you the understanding that children are they can be involved in their meeting once they get a certain age. So yes, when it comes down to the appropriate services that are needed with these individual education plans, this is called the IEP. It is put in place, and the student, it goes with the student all the way through school, still can go into their college years with them as well, needing the special education needs that they have, meeting the special education need, meeting, excuse me, meeting the special education needs that they have. All right. So when we're talking about the individual education program, the IEP, we want to make sure that we are on point with that. This is going to include a lot of your healthcare, mental health, psychiatric, and your occupational needs, as well as your physical needs and different things that's dealing with individuals' developmental achievements as they're developing through school, so that we can make sure that they are getting their academics along with getting their special education needs met. Outcomes, when we talk about outcomes at the individual level, evidence used to determine the extent to which service uh, recipients improve their level of functioning, improve their quality of life, and attain personal life goals, such as results of treatment, services, and other supports provided by the public and or private systems. At the same level, outcomes are events used to determine if the system is functioning properly. So basically, outcomes we're wanting to see, and we've already talked about outcomes a little bit because we talked about going from the assessment to the treatment planning, and then to the treatment that we're rendering, and then going into the effectiveness, as in the outcome, the evidence-based outcome of the services that are being provided. So when we're in services, that's what's happening throughout anybody's career, anybody's time in treatment, anybody's whatever their, the services outcome is what we're looking for. We're trying to figure out what the outcome is. Even if we're looking at the educational service, we're trying to figure out what the outcome is going to be, what's going to be most appropriate for the person to quote unquote improve, or that making sure that they are able to obtain these goals. Okay. So we want to make sure that we understand that we are looking for outcomes on all levels of services that we're providing, whether it be education, or whether it be mental health, whether it be substance abuse, whether it be medical services to get a person well, get them, past their current condition and into a better state of, if we look at cancer and things like that, we're talking about being in the state of remission, so different things of that nature. We want to make sure that we have an outcome. All right, so person-centered planning, we're talking about an approach in which the individual directs his or her own planning process, with the focus being on the express preferences, needs, and plans for his or her future. So outcomes come up when we're talking about the person-centered plan. We want to make sure that we are addressing the whole person. We are looking into wanting to help that person get to their desired goal. A lot of times I tell people also, the process involves assimilating a group or of supporters as a on a need as need basis, people who are there, that are selected by the individual with a disability, who have the closest personal relationships with them, and are committed to supporting the person in the pursuit of real life dreams, things that they want to do, things that they want to accomplish, goals that they want to make sure that they accomplish, and they do it in the most appropriate way. When we're talking about those involved in the planning process, they're interested in learning who the person is as the individual, and what he or she desires are for their life, what they're wanting to do. The process also is the interest in identifying and gaining access to supports from a variety of community resources and different service out there. One of which is community NH. I'm sorry, this would be MH is in there, but MH mental health, IDD intellectual developmental disabilities, and SU, which is substance use services system that will assist the person in the pursuit of life, a pursuit of life that he or she wants to live, and the life that they want to, the role they want to be in that in their life. So the person-centered plan is a results in a written individual support plan that goes with the individual. Okay, individual support plan, of course, and then we're talking about the PCP. When we're talking about the person-centered plan, going into that, the individual is an individualized and comprehensive plan that is specific to all the services. It specifies all the services and supports that to be delivered to the individual eligible for mental health and or developmental disability and or substance use services according to the North Carolina mental health reform requirements. So a person-centered plan generates actions or positive steps that the person can take towards realizing a better or more complete life. Plans also are designed to ensure that the support are that are delivered in a consistent, respectful, manner, and often and offer valuable insights into how to assess the quality of services being provided. So a lot of times it's making sure that we are involved in that process of making sure that these services are being carried out. All right, so a qualified professional individual that's working with that have the appropriate training and experience in the field of mental health, developmental disabilities, or in substance use treatment services specified by the general statute or by the rule. So basically, there is a general statute that tells you what qualifies as a qualified professional, a AP and a PP. So your paraprofessionals and your associate professionals as well as your licensed professionals, and then the other licensed professionals that work within the services. The recipient, of course, is the person who's authorized for Medicaid services or other programs, or insurance benefits, insurance coverages, the individual receiving a given service. We're talking about referrals. We're talking about the process of establishing a link between the person and another service or support by providing authorized documentation of the person's need and recommendations for treatment, services, and supports. And it also includes follow up in a manner of consistent with the best practices guidelines. So making sure that the referrals are the person's linked, making sure the referral is known about, you give them the resource, tell them about it, making sure the individual's linked to the services, and then making sure that there's some follow-up on the person getting into the services and that things are moving along quite smoothly. Screening process also talks about is basically talking about the assessment. Basically, when we go through the screen, making sure the person intended it is we have questions that are intended to make sure to determine whether the person needs referral to a provider for additional services. So we're trying to make sure that we're, getting the assessment. It's usually abbreviated assessment, and it basically talks to making sure the person is being screened appropriately. Screenings can happen face to face or by phone. It's usually done by a clinician or a paraprofessional or a qualified professional who has been trained to conduct screening services. And pretty much the screening is the core basis to make sure that the services are available to anyone who needs it, and whether or not they meet the criteria for the services. We talked about screening a little bit earlier on, making sure that it's the target an appropriate population for the individual to be getting those services. Okay. So these are a magnitude of things that we kind of just went through and we're talking about documentation. We will go specifically through more documentation training, giving more bases and more information. But this is just an intro to talking about documentation and understanding what documentation, why it's there, and why we need to have this training, and why we need to have this supervision, and why we need to have specific ongoing trainings, ongoing supervisions, and ongoing staffings and different things of that nature when it comes to documentation. It is very important. I usually tell individuals this is how the company gets paid. This is how the services are rendered. This is how the contractors are employees. This is how you get paid. This is how we make sure that it is an accountability system in place and that we are making sure that the funds that are being received for the services that are being provided are accurate and are on point and meets the guidelines. So this is the reason why we are putting this training out there and making sure that individuals are aware and they are definitely understanding what it's all about when it comes down to providing services in the human services field, in the healthcare field, in any field for the most part when it comes down to documentation. So we have to be aware of it, and we have to be more so in the mindset of making sure that we understand what's happening. I thank you for listening to this presentation. And if there are any questions or concerns, of course, you can always reach out to me, Dr. Latasha McElwain, and we can go from there to be able to assist and help individuals accurately and be supportive in making sure that your documentation is on point.